implies that you're fine to be part of a recorded event. The program tonight carries 1.5 hours of physician category 1 AMA CME credit. It also carries 1.5 hours of Virginia Nurses Association CEs. Included within that 1.5 hours is 0.75 nursing hours CEs in pharmacology. We're delighted we can provide that for the nurses on the call this evening. Sovah Health is accredited by the Southern States CME Collaborative to provide Category 1 CME, and we are also accredited by the American Nurses Association Credentialing Center Commission on Accreditation to provide nursing CEs. The two lectures this evening were developed to promote several desirable physician attributes, including patient-centered care, utilizing evidence-based practice, our working in interdisciplinary teams, and our use of informatics. No one on the program tonight has any commercial relationships to disclose, including Dr. Anderson, Dr. Dodd Ashley, myself, and members of the Sovah CME committee. Similarly, there is no commercial support for this program this evening. It is supported by the Ralph Landis Medical Education Fund, which resides at the Danville Community College. That fund created when Dr. Landis retired from active practice at the Danville Urologic Clinic, provided an endowment for nursing education for all and physician education throughout this local area. We're very grateful for that endowment. Today or in the morning, you will receive an evaluation form. I have to remind everyone that that form will include a request for you to re-enter your name and your email so we can send you your certificate. So please use your full name on this re-registration on the eval form. No nicknames, please, in as much as your certificate will have that name that you therein and enter. I also need to remind the nurses that your eval form is required in order to receive CE credit. That's not true for the physicians. We hope all of the physicians will provide us an evaluation, but if you do not wish, someone needs to mute their phone, please. But if you do not wish to do an eval form, please let us know so we can be sure that we get you a CME certificate. A new option for the eval forms is our providing a QR code within the chat box on Teams. And at the end of the program, that QR code will be available in the chat. If you want to click on that, you can go directly to it. Otherwise, you will still receive one by email this evening or in the morning. For Sovah Health residents on the call, first of all, we're glad you're on the call. But we need to let you know that your program coordinator, that is Dara Johnson or Lori Galvez, are aware of your participation this evening. They track your participation, so you do not have to keep up with CME certificates. Otherwise, we will send out the certificates once we receive your eval forms. I want to especially thank Mary Kent for her hard work in allowing and providing this program to occur. As our CME coordinator, she does all the documents and the linkage and makes everything work so well. And likewise to Vandora Holt, or Van as she's known to her friends, for managing and providing the nursing CE credit. If anyone on the call this evening has any questions about content, follow-up, eval forms, certificates, please reach out to one of the three of us and we'll be delighted to help you with that. We encourage your questions and engagement with the speakers. Both will be asking you for questions and comments. If you do so want to make a question, once you've asked it, please mute your phone so we don't get feedback. And the answer, you're certainly welcome to do as many questions and comments as you want to do. In addition, Mary will be monitoring the chat, so if you want to send in a comment or question through that, it will be fed through Mary back to the speaker. I want to remind you of some upcoming CME programs we have scheduled. In 2 weeks, we will have the second infectious disease program for this month. And as you can see on the slide, this will be a discussion of antimicrobial stewardship in the outpatient setting. Most of the focus on most talks on antibiotic stewardship focus on inpatient care, but this will be a particularly targeted outpatient review of what's currently best practices by Dr. Mooring, one of the infectious disease physicians at Duke. And following that is what I think is will be a very helpful program. We're going to talk about the reportable diseases of Virginia, the ones that are required by law to be reported and tracked, and the process that is used for that, both in the sense of what you have to report, how you report it, and what happens, particularly to your patient and their family, once it's been reported in some cases. And we're delighted to have Dr. Spillman, who's our local health department director, and Paige Bordwine, who is the regional epidemiologist for our part of the Commonwealth, who will be talking about that in 2 weeks from tonight. In February, we're going to have 2 evenings on cardiology. The first will be an update on atrial fib management by Dr. Pacini, who is the electrophysiology section chief at Duke. And that'll be followed by a review of anticoagulation management of deep vein thrombosis, pulmonary embolus, and management of patients who are undergoing surgery who are on chronic anticoagulation, so-called bridge therapy. Then the second talk on February 13th will be a review of the new American Heart Association guidelines for cardiovascular management of patients undergoing surgery. These are brand new cardiology guidelines that were released late last year. Dr. Jen Reimer, a cardiologist in the Duke group, was a lead co-author of this large consensus panel American Heart put together for the guidelines. So this will be a unique time in order to have her explain what's new in the guidelines. And then the last talk in February will be a GI talk by our own local Sovah Health, Dr. Kimberly Beavers, on screening for colon cancer, who should be screened, why it's screened, and the various techniques that are currently available. So this evening, we're having our first infectious disease annual review, as it were, and we have 2 speakers, as I'm sure you're aware. The first is Dr. Debrick Anderson. Dr. Anderson leads the Duke Center for Antimicrobial Stewardship and Infection Control, known as DASON. Just so you know, Sovah Health, and before that Danville Regional, was one of the earliest members of this organization at Duke. It provides services to numerous hospitals up and down the East Coast and central part of the United States, and helping them monitor their infection rates and prevent recurrent infections and manage things that occur in those centers. Dr. Anderson will be doing the first talk. And then secondly will be Dr. Libby Dodds-Ashley, one of the PharmDs at DASON. Let me tell you a little bit about Dr. Anderson, who many of you know and have heard his talks before. We have him do this annually. He started his education at UNC, where he graduated with highest distinction in biology and was a member of Phi Beta Kappa. That was followed by his MD at Duke, where he was a member of AOA, the Alpha Omega Society, which is the highest honor society for medical students. He then remained at Duke for his internal medicine and infectious disease fellowships, but returned to Carolina to UNC for his master's in public health and epidemiology. He is an extensively well-published healthcare professional with over 200 peer-reviewed publications, 26 book chapters, and has participated in 16 sets of consensus guidelines. He currently sits on the CDC's Healthcare Infection Control Practice Advisory Committee, and he's currently the director of Duke Center for Antimicrobial Stewardship and Infection Prevention, as well as leading the DASON network. The other very interesting thing about him is he is a owner and co-founder of the Infection Control Education Organization for major sports, and that includes the National Football League. So he is the one that helps the NFL, and there are many teams who are all engaged in year-end competitions now as far as preventing infections, managing potential infectious issues within their organization, their locker rooms, etc. And he's had that similar experience for at a national professional level for basketball, hockey, baseball, soccer, etc. It's a very unique experience. So, Dr. Anderson, we're delighted to have you. If you want to bring your slides up, I will bring mine down, and it's all yours. Thanks a bunch.
That's great. Thank you so much. And just to confirm, you can still hear me, Mike?
Yes, you sound good and we can see you.
Okay, very good. Thank you. And here we go, pulling up the slides. And one last check. Everybody can see those okay, I hope.
They look good.
Okay, thank you. Well, I will jump right in then. Well, Mike, thank you again for that really nice introduction. As always, it is a great pleasure to provide some educational information for you there at in Sovah. As you said, Mike, you know, Sovah and Danville in particular has been a long-standing member of the different networks that we have here, and it's always great to interact and again, provide hopefully what's be some useful information. So the topic that I've been tasked with is what you see here, multi-drug resistant organisms. We're going to go through trends, some observations, and then, of course, most importantly, some strategies to address. The objective for this part of the evening is that those that are listening will have improved competency in identifying and preventing infections caused by multi-drug resistant organisms, or MDROs. You'll probably hear me use that abbreviation several times through this lecture. Now, I had originally thought I might focus on 3 different MDROs, and I thought as I was going through this that there was enough information to provide about these 2 that it was probably worth just focusing on these. The other one that I had originally was C. difficile. I actually gave a lecture related to C. difficile there for Danville back in the spring, which hopefully is still available if that's a specific topic of interest, or if you'd like to reach out, certainly happy to talk about that specifically as well. But for us tonight, I wanted to focus on the 2 MDROs that you see here, Candida auris, and then more like a kind of a category of multi-drug resistant organism are multi-drug resistant gram-negative rods. And then honestly, for each one of these, there is more than an hour's worth of information, of course, that we can go through and that we can try and understand. And so what you'll be getting from me really is in some ways just kind of scratching the surface about information related to these. But again, the goal here is to make sure that there is some awareness of these, understand why it's important for us to focus on them. And again, ideally start to provide some information about what should you do if you find one, how are you best going to identify them, and some of the downstream issues that come up when these occur in patients in our hospitals. So this is a big picture estimate. This is from the CDC. It's from a few years ago when they look at the threat of antibiotic resistance in the United States. So that includes bacteria with resistance. That's what our gram negatives are going to be. And fungi with resistance. That's what Candida auris is. When you put all those together, you know, some of the recent national estimates out of the CDC is that this causes upwards of 3 million infections each year, and causes almost 36,000 deaths each year, as you see on the left side of this column. When you look at some modeling predictions out of groups like the WHO, and they talk about, well, how many different patients will there be with multi-drug resistant organisms in the next couple of decades, the numbers get pretty staggering when you talk about worldwide impact of antibiotic resistance. I mean, literally models predicting millions of deaths related to this issue. So it is definitely one we have to pay attention to and ideally come up with our best strategies to prevent and again, over time, hopefully decline and decrease the trends that we've been seeing. So let's focus the first part of our discussion tonight on Candida auris. What is it? It's an emerging fungus. Again, Candida, everybody is, of course, familiar with that term. You know, Candida is overall is a very common type of fungus that we see. We all have it on our skin, but this is a different type. Candida auris is more or less relatively new, and it's identified as an emerging fungus that when you put all of the trends together represents a serious global health threat, excuse me. As you see here in bullet form, why? Why do we think this? Well, we're already finding it all the way across the world. It's essentially already just about everywhere. And in most places where we are able to track it pretty well, we're finding that it is increasing. Candida auris, again, like Candidas, can live on the skin, but when it's there, can colonize patients for months to years. And we currently do not have good strategies to get rid of it when a patient has it. When an infection occurs, and we'll get into this in a little more detail, these are frequently very serious infections like candidemia, where we see Candida auris in the blood, and have very high mortality rates, as you see here quoted at upwards of 60%. One of the reasons that's the case is that it's difficult to identify and difficult to treat. They are sometimes resistant even to some of our very strong antibiotics, like our echinocandins and some of our triazoles, and even sometimes amphotericin, which for the longest time, of course, is been kind of the backstop for the types of terrible fungal infections that we'll deal with. Some have been identified that already have resistance to all three of these different classes. So definitely meets the definition of multi-drug and highly drug-resistant pathogens. Because this is relatively new, our laboratory methods have gotten a little bit behind in how best to identify them. And unfortunately, if we use some of our standard approaches, can actually be misidentified, which, because it's often resistant, then leads to incorrect treatment. You put all that together, and then that's where you can start to get some of these bad outcomes for patients as well. When it occurs, especially in hospital settings, it is frequent cause of outbreaks. And for this reason, it's really important to identify when it is happening in a hospitalized patient. And as we'll get to at the very end of this, there are actually some specific recommendations about how best to then identify if anyone else near to that individual patient has already acquired the organism. So why is it a problem? Candida, when this Candida auris causes infections, these are serious infections in the blood, around the heart, in the brain, resistant to medicines, more common, difficult to identify, and it spreads. So if you're a visual person, you like your kind of visual abstracts, this is a lot of that same information in just a little bit more of a visual form. It was first identified in 2009 from the ear discharge of a female patient in Japan. And then at this point, here we are 10, 15 years later, we're already seeing it again in almost most large countries in the world. High levels of mortality. Who does it infect? Most of the time when we see this type of infection, we're talking about patients that have immunocompromised status of some sort. That does include diabetes, but of course, chronic kidney disease, hemodialysis, lots of invasive devices can all put people at risk for these types of infection as well. I mean, again, it's a candida. It can colonize just about any part of our body. Any of us have different types of candida that really are already all over our body and inside our gut. So that's not a surprise. What, again, is the surprise is that this newer candida is already then resistant to these organisms. And so if you see this figure, you move from left to right, this colonization where it can be just about anywhere, to infection, unfortunately, because it can be just about anywhere. When you connect that to some highly immunocompromised patients with these invasive devices, it can then get in to just about anywhere as well. Because if you look up and down the list related to infection here, and there's hardly anything that's missing from this list as potential infections that this pathogen can cause. As we'll get into when we get into the infection prevention side of our discussion, one of the issues we deal with in the hospital settings that it is actually more difficult to disinfect from the hospital environment. Again, we'll put a pin in that for now and come back to it momentarily. So when we think about these hallmarks, what make it this major public threat, this figure is intended to kind of connect these things we're talking about. It's increasing in its prevalence. What is the threat? Well, if it continues to increase in the future, then we're going to see more, not just across healthcare overall, but in our hospital and with our highly immunocompromised patients. If it emerged multiple places all at the same time, and we know that these worldwide dissemination, as we are all too familiar with right now, can lead to pandemics and high levels of increasing in prevalence in many places across the world all at the same time. Because our labs don't always identify this correctly, we then have delayed recognition, which impacts patient outcomes. This is difficult to eradicate, gets on prosthetic material, forming biofilms, and that increases our risks of patient to patient, patient and interhuman transmission, especially in our healthcare settings. And then finally, this issue of antifungal resistance. Well, the threat there is that these resistance factors continue to accumulate. And while we may have some options now, are we going to get to a point where we essentially run out of most of our standard antifungal agents, which of course would then increase this issue even more, and of course lead to even worse outcomes for patients afterwards. Now, my goal here is not for you to read every single word that's on this. This is actually specific content that's lifted from the CDC website that you see here. And what we're getting at, what my main point of this is to say that the issue of trying to figure out which antibiotics work best against Candida auris is not a simple issue. As of now, there are not any standardized susceptibility guidelines for based, from the CLSI, from our microbiology laboratory, about what we should be using. We're all familiar with seeing things like S for susceptible, R for resistant when we look at susceptibility reports. And we're still figuring a lot of that out when it comes to how to deal with Candida auris. And so what you see listed here for your different drugs and drug classes. So the bottom left-hand corner, you see some of our azoles like fluconazole and voriconazole. We have tentative MIC breakpoints that we can try and use as a guidance, not that this is a definitive type of definition. Upper right-hand corner of your polyene class like amphotericin B, so isolates with an MIC of greater than or equal to 2 should be considered resistant based on some emerging data that they have. And then same thing with the echinocandins that you see below that. Some differences perhaps depending on which echinocandin you're talking about, but tentative breakpoints. What does this mean? Well, basically, should you identify Candida auris in your lab, you're going to have to work closely with your laboratory and maybe even some outside laboratory testing to best understand how to deal with this agent and treat it successfully. When you look at what are some of our standard recommendations for how best to treat and manage a patient that may have a Candida auris infection, again, this is from our CDC website. And one of the things that you first see from the CDC website is that should you find this organism, that it's highly recommended that you try and get infectious diseases providers involved. Keep in mind that even if we're treating infection, the risk of that for that patient is not decreased thereafter. We think that Candida auris is going to stay on that patient's skin and maybe in their gut, and a colonizing agent for long periods of time, maybe even for thereafter. So what is our treatment choice as an empiric option? As you see listed here, it would be an echinocandin, and you see that better expanded in the table to the right. Anidulafungin, Caspo, micafungin with specific dosing recommendations are provided by CDC. With the caveat that, of course, this is empiric treatment. We still would like to better know from more advanced microbiological testing what some of the MIC breakpoints might be so that we can identify resistance if it's present. While you're waiting on that type of testing, you can still make some types of clinical adjustments if necessary, as you see from this last bullet. That is that if the infection you're treating is unresponsive, which means ongoing persistent fungemia and symptoms for greater than 5 days, and CDC recommends at that point we switch to amphotericin B. Now, sometimes you can add that as a combination, but now you're getting way off into areas where there's some potential theoretical benefit, but our clinical experience with those kinds of strategies is very, very limited. So if it's an issue and we identify a case, how do we stop it from spreading? And what you see across the top of this table are the different types of infection prevention strategies that are generally recommended, again, across the world. We're talking about CDC, England, European CDC, and different groups like WHO. And so active surveillance, if you find one case, there is some value. And again, as I'll show you in a moment, CDC recommends that we do some additional screening of patients. Hand hygiene, luckily still soap and water it works. It can be recommended. Alcohol is still recommended by CDC, though it's a little bit on the controversial side, as there's some concern that maybe alcohol is not quite as good as soap and water. Definite put these patients in isolation and contact precautions. And then environmental disinfection, as I'll show you in a moment, there is some adjustment that has to be made from the infection prevention side when we deal with this particular type of infection. This expands on that. And again, this gets into the weeds a little bit, but I think it's important to just kind of relay this content because it is, I think, one of the main factors that we struggle with and why this can spread within hospitals. The vast majority of hospitals across the US use what's called a quaternary ammonium disinfectant. We call that quats for short. But we've learned over the years that quats are not effective against certain pathogens like C. difficile and norovirus are the top two we routinely talk about. You have diarrheal illness, you probably want to use something other than that standard disinfectant. Well, now we have to add Candida auris to that list as well. And so when it comes to things like hand hygiene and using soap and water and how we disinfect environment, we use things like bleach or hydrogen peroxide. Candida auris is a little more similar to something like C. difficile than it is to something like Candida albicans, which we think we can pretty easily get rid of from these other settings. And then finally, for Candida auris, public health screening. The idea here is that when you have patients who are high risk for Candida auris, there's some current recommendation that we provide some type of screening. What are the definitions of what we call high risk? Well, one, it would be contacts of patients that have newly identified infection or colonization. Here at Duke, we had our first case of Candida auris earlier in the spring of 2024. And this on the transfer of a patient, a highly sick patient in one of our CT ICUs here, we then did essentially what we call kind of like concentric screening, where you first look at the people that are closest and try and observe if anybody else has obtained this. And sure enough, we found that at least 2 other people had colonization with this organism as well. And so then you start looking at those contacts, and you kind of have to cast this net to better understand kind of where this organism is to then put in place better practices to stop it from spreading further. Now, there are other categories that we have under this definition of high risk. Patients with an overnight stay in a healthcare facility outside the US. This was one of these risk factors we talked about a lot about 10 years ago when it comes to like healthcare tourism. This as a risk factor for different types of drug-resistant pathogens. Well, now Candida auris is on that list as well. Roommates in healthcare facilities, including nursing homes, where we know there's been a patient that had this type of infection. And again, it provides some specific, we don't have to get into this necessarily, but just for your information, there are specific recommendations for how best to swab and screen patients for this organism. Now, the good news here is that when I talk to the infection prevention folks in Sovah at both of your facilities, as of yet, you have not seen this organism, and that's good. I think this puts us in a good position to try and give you the information that you see here in front of you, because I am, here to tell you that you're very likely to see this there at one of those facilities, if not both, sometime in the near future. It's that type of increasing trend that we're seeing. We're expecting this to be much like an organism like CRE in most, if not all, of our facilities across the US. It's just a matter of time. So hopefully it won't, but if and when it does, hopefully this information that I provided gives you a little bit of foundation for how best you're going to have to deal with it thereafter. Okay, and with that, we'll pivot over to multi-drug resistant gram negatives. A few key points, we use a label like multi-drug resistant gram-negatives. And, when we think about different types of gram-negative organisms, we'll typically think of things like Enterobacterales, which is our gut type of organisms. Think of E. coli and Klebsiella. And then we'll think of our what we call non-lactose fermenters. That's what we call them in the lab. Pseudomonas, Acinetobacter, some others kind of fall into that category. Well, when it comes to the gut-related gram-negatives, like the Enterobacterales, when we think of resistance, we think of acquired and transmitted types of resistance mechanisms. ESBL is the most common type of this transmissible and acquired mechanism. Other ones are carbapenem-resistant mechanisms as well. And these, when they're found in one, like a Klebsiella, can be transmitted to other organisms and increase spread of these types of resistance through things like plasmids. When it comes to Pseudomonas, Acinetobacter, and other non-lactose fermenting gram-negatives, these typically have machinery in place already, this intrinsic resistance mechanisms. We all know that you have limited options when it comes to Pseudomonas, the treatment of Pseudomonas or Acinetobacter. It's because all of them already have the machinery to have resistance against a lot of the antibiotics that we use. Now, a little bit of local data for you to help with this conversation. What you see here is the antibiogram, first from Sovah Danville. I'll show you Martinsville next. And if you haven't seen, hopefully you've seen something like this. If you haven't, just to make sure you're oriented to it, we treat these kind of like our tax returns. You do these, can do these, once a year, and it helps kind of summarize how things were for the past year. And so what you see at the top of this, most relevant to our discussion, is the cumulative 2023 gram-negatives, the most common ones you see here. The next column next to the name is the number of isolates that were identified by the microbiology lab. And then as those columns continue, you see in alphabetical order different antibiotics that we might use against some of these gram-negatives. The number that you then see in that column for each individual organism is the number that were susceptible. And so if you go across an Enterobacter and you see the red nitrofurantoin 22, well, right off the bat, 22% of Enterobacter are susceptible. Flip that around, 78% are resistant to nitrofurantoin. We're not going to use nitrofurantoin for Enterobacter. And it's in red because the amount of resistance had increased by more than 5% than compared to the prior year. Now, what I've highlighted here is I think what's most relevant for us is, E. coli and Klebs are our most common gram-negative pathogens. And you there at Danville, just like we have here and many, if not most other places across the world, frankly, I was going to say the US, but this is a trend across the world, is you have an increasing number of ESBL E. coli's and an increasing number of ESBL Klebsiella isolates as well. So again, if you haven't seen it, again, you're probably just lucky given the number that are present. It's a trend we're seeing everywhere. Same thing in Martinsville. And so it's perhaps slightly lower as far as the cumulative numbers. 11% of the E. coli in Martinsville were ESBLs, 7% of the Klebsiella were over 2023. And so, again, these are not necessarily things that are so common that right off the bat, we are immediately changing antibiotics to cover this, but we need to be able to identify it and make sure that when we see it, we know how to treat it. And so that's what I wanted to then, well, I'll focus on that in a moment. So what about these increasing trends? Well, the COVID pandemic did not help us here. This is data that's published by the CDC. And as the COVID-19 pandemic unfolded, we saw resistance increase almost across the board. ESBL, E. coli, and Klebsiella, carbapenem resistance in the same organisms, Pseudomonas with resistance, Acinetobacter, and even some of our gram-positives, just to complete the figure here with Enterococcus and Staphylococcus aureus. And you might say, oh, well, those are just big institutions, right? That's just where this stuff has happened. Well, we actually saw this same trend in some of our DICON and DASON hospitals as well. We were pretty happy before the pandemic. We had actually been making some really good progress in decreasing the amount of CRE we were seeing in the community hospitals that we had been working with. But unfortunately, that trend was disrupted and even turned around, as we're seeing now, increasing numbers of CRE once again since the beginning of the pandemic. So not only is this happening, of course, in our big tertiary care centers, but this is all data from community hospitals, including your own, over the past several years with these increasing trends. So we're going to go through 3 different strategies that fall under this category. We're going to identify and treat these different organisms to the best extent we can. What we're going to focus on primarily for treatment is this increasing trend of ESBLs and how we might deal with those based on recent guidance when we identify them. So the next 3 figures are set up similarly. What you're going to see on the left is the type of diagnosis. In this case, we're talking about just simple urinary tract infection, uncomplicated cystitis. And in that setting, there are a few other options besides some big guns. And so you can use, can often use some things like nitrofurantoin and trimethoprim sulfa. There may be some others that are like Cipro or Levo, and then oral fosfomycin. And one of the things to point out here is that when you have an ESBL, not only are not almost all, if not all, of your beta lactams knocked out, but frequently those have additional types of resistance. So even though there might be something like preferred, you still want to see what your susceptibility report showed. And sure enough, of course, if it's a urine sample and it says it's resistant to these agents at the top, you still want to try and find something that it's susceptible to. What it's saying don't do is, even if for some reason you see that it might look like it's susceptible to doxycycline, is don't use it when you have an ESBL in place. Same thing with amoxiclav or Augmentin. If you make it slightly more complicated, but not yet to systemic, bacteremia, pyelonephritis, complicated urinary tract infection, then your options decrease. Even if it looks like it's susceptible, it's not advised to use nitrofurantoin or doxycycline, for example. Plus or minus on aminoglycosides, most of us probably are not pulling those off the shelf anyway. But if susceptible, you can use a fluoroquinolone. You might be able to use Bactrim, but carbapenems, of course, now are added to this preferred list. If you then get into even more complicated, then essentially the only preferred option becomes carbapenems. And so infections outside of the urinary tract, should you find something like pneumonia, but most commonly probably what we have to work through is issues like bacteremia, and meropenem, ME, ERTA would all be options. Perhaps there can be some alternatives after you've had a clinical response like your Cipro or your Levo, if susceptible, but not for your initial treatment of these much more serious types of infections. And I should mention, these are references, maybe hard to read. This is all based on Infectious Disease Society of America, IDSA, treatment guidelines for these types of infections. We'll now turn our attention to what we call cascade reporting, and this is related to the types of data that you're going to get from your microbiology lab when a specific gram-negative organism is identified. And so, as you see here, cascade, or also known as selective reporting, is a stewardship strategy that we can use and is in place now there at Sovah that's going to help encourage the use of the most narrow spectrum agent for a given pathogen. Susceptibility results for secondary, which are often much more broad agents, are only reported if the organism is resistant to first-line, more narrow agents within a specific drug class. And I'm going to walk you through a few examples of what this means and what this looks like. And again, to reiterate, you have this cascade reporting in your 2 institutions. It's used for a variety of drug-bug combinations, and it follows, as you see here, CLSI guidelines and recommendations. Agents that are tested and are resistant are going to be reported. But what you'll find as we go through some of these examples is there are other agents that would be susceptible, but they would be assumed to be susceptible based on the additional susceptibility results that you are actually provided. So again, reiterate that point. If it's resistant and it's one of our standard antibiotics, you're going to see that data. Okay, here's, I think, the most broad example. This is back to this Enterobacterales. These are gut organisms, E. coli, Klebsiella. I think the third row is the one that's most relevant to go through. Something like ceftriaxone. Every time you have an isolate with E. coli, you're going to know if it's susceptible or not to ceftriaxone. If it is susceptible to ceftriaxone, you will not see susceptibility data to cefepime, ertapenem, or meropenem. It is assumed that it is susceptible to those, but use of those is unnecessary when you have ceftriaxone to use. Should you have ceftriaxone resistance and then cefepime resistance, then the next tier would then show you if there was ceftaz avibactam resistance in testing as well. And so tier 1 always reported. You're going to see susceptibility data for each of these that you see listed here anytime something like E. coli is provided. But you might not see the things that are in tier 2 or thereafter if what is available in tier 1 is susceptible. So another example, E. coli in the urine, pan-susceptible, susceptible to ceftriaxone and gent. You're not going to see the results for these others and still could be considered pan-susceptible. You see a few little footnotes over on the left, not salmonella, not shigella. All of this is available in content that you have there. And these details are available in the content that you have in Sovah Health and your 2 institutions. On the left again, now we're talking about Pseudomonas. And so ceftazidime and cefepime, when it comes to Pseudomonas, will always be reported. If ceftazidime resistant, you'll then see if meropenem, your carbapenem option, is susceptible or not. If it is also resistant, then again, just like the others, you'll see ceftaz avibactam if the meropenem is resistant as well. Again, with Pseudomonas, we have more limited options to begin with, so there's not necessarily quite as much cascade reporting for that organism. Other Enterobacterales, there's some, or odd ones that come up here. You'll see, you're going to get gent, tobra, piptazo, and trimethoprim sulfa. If there's any resistance in those, you'll then see some of these other potential options depending on which organism it is. And again, the cascade continues from there. Acinetobacter, another similar one, limited options to begin with. But again, the main points here are there's several. One, all this is in place at Danville and Martinsville at Sovah institutions. All the data that the content that I'm showing you here is directly from the policies and microbiology laboratory information that's available to each and every one of you. And it's all there with all the details provided as well. Okay, the final component of my talk here is related to changes in diagnostic testing that you also have available for you at Danville. I keep saying Danville. That's where my long-standing work with Danville comes into play. I mean Sovah when I say that. It's both institutions. That is the rollout of the BCID2 blood culture testing abilities for the microbiology lab. So what is BCID2? It is a PCR-based test that can identify up to 26 different types of bacteria, 7 different types of yeast, and then has some in PCR targets against specific genes that confer antimicrobial resistance. Now, those are nice numbers. It's, again, a great strategy, but that's not every single organism that we deal with out there, right? So keep in mind, many other organisms can cause infection. This is not run on every single bit of blood that's sent down to the micro lab. First, you have to have an initial blood culture with a positive gram stain. Once the gram stain is positive, then this test can be used. And sometime between 2 and 24 hours later, you'll get some results. Why the range? Depends on what time of day it is. It depends on, is it night versus morning and what the staffing is, if it's weekend. All these can kind of factor in. It's a pretty rapid test, as you can see, but there's some variation related to practices in the lab and the timing. So again, reiterate it one more time, a negative BCID2 does not rule out infection. You have a gram stain that's positive, your BCID2 is negative, that means there's a pathogen present that's just not yet identified because it was not one of the specific targets. Now, with each one of these, there are specific blood culture treatment pathways and ways to interpret that. I'm going to show you one example of that. And keep in mind that pharmacists are there and able to assist you with antibiotic dosing and durations for all these patients that have bacteremia. And if you look at not only things that we do here at Duke, but things that are highly recommended amongst various infectious disease societies, ID consultation is also recommended for patients with blood cultures that have Staph aureus, Staph lugdunensis, and certain gram-negative resistant organisms like we're talking about here, and fungemia or candidemia and candida species. So here's an example of a table that you'll see in one of these culture treatment pathways. This is specific to gram-negatives, and this is only a portion of the gram-negative target. These are very detailed tables, and what you're seeing here is only an excerpt. And so again, just to make sure you are oriented to what we're looking at, you first are starting with the BCID2 group target. And the main one here down at the bottom is Enterobacterales. Again, E. coli, Klebsiella, things like Enterobacter. We'll get there in a moment. There are some that don't have this larger family to go with, but just have the organism. That's where you see this BCID2 pathogen target. You got Acinetobacter, Bacteroides, and then what I have for you here are 5 different types of these Enterobacterales. Again, there are specific PCR targets that can say that yes or no, one of these specific organisms is present. Let's say it's an E. coli. Then next you'll have BCID2 looking for specific genes that might confer different types of resistance. So CTXM is our ESBL resistance gene. And then you see 5 different genes here, KPC, NDM, OXA, IMP, BIM. The specific type doesn't necessarily matter, but what we're talking about there would be a carbapenem resistant E. coli. And then, so that helps you identify rapidly what organism you're dealing with, and it's most common and most feared types of resistance. But the good news here is within this blood culture treatment pathway, you also then have specific empiric antibiotic recommendations depending on what these results show, right? So if Bacteroides is identified, first line empiric treatment, metronidazole. If E. coli is identified, but no resistance organisms are found, resistance targets are found, ceftriaxone is the recommended agent. If an ESBL was found because it hits the CTXM, then like we just talked about, maybe there's some differences depending on what type of infection you're talking about. But if it's bacteremia, like we're dealing with here, then back to what we were saying before, meropenem is the treatment of choice. And then just to add one more example, if it's E. coli and it is not, and we find a KPC, carbapenemase positive, then we would say you need to consult ID and get some input into what best to do for those types of patients. Again, these are things we could go into and get into all kinds of detail. That's not my intent tonight. This is really just to make sure you are familiar with what this looks like and that you know that it exists, not just for gram negatives, but for other types of organisms as well. And it is a really, really useful tool that's going to help, we think, provide a lot of really good information and put patients on important and more appropriate treatment choices when these different things are identified in blood. Okay, wrapping things up for the first part of our lecture series tonight. Again, lots of information. This category of just kind of drug resistance is a really, really broad category. When you look at it in that broad sense, then we know with certainty these are problems. They cause a lot of patient suffering and have high rates of mortality. Some differences, perhaps, depending on which organisms you're dealing with, but go back to that initial number with something like Candida auris. We're talking about 50, 60% mortality rates in patients that have this in a severe infection. It's really, really high. We are seeing this increase across the world when it comes to multi-drug resistant organisms like Candida auris and our gram negatives, especially our E. coli's and Klebsiellas in particular. So again, good news, you haven't seen something like Candida auris yet. You're going to eventually. You haven't seen a lot of carbapenem resistance, you're going to see more of it. I feel it's pretty certain you're seeing some ESBLs, but if you haven't, you're going to see those as well. We are seeing this trend all across healthcare in all settings. But in the meantime, we do have tools that hopefully we've been able to, again, point you towards and have available for you to use, how to better diagnose and identify these different organisms when they're present, some tricks and some tools to better treat these organisms with the most appropriate antibiotics, and then, of course, how to prevent transmission when one of them is identified. So with that, I'll wrap it up, and I'm happy to try and address any questions. And I'm going to take it off of presenting, so hopefully I can see if there's a question or someone goes up on screen.
The questions for Dr. Anderson, please speak up. There are no dumb questions. This is stuff that most of us don't deal with every day. New words, new names, so it's that way in general.
Frank Walsh, neurologist here. I have a question. Will CSF be treated like blood cultures if there's a positive gram stain? Will it go for the PCR testing automatically?
For this specific testing strategy, no, this is very specific to blood culture. There are other various PCR panels that related to CSF that are available, but what we were discussing tonight was specific to blood cultures, to be clear.
Okay.
Other questions? One of the comments Dr. Anderson made to me when we did a test connection to, as we always do, to go over sort of how things are going to run, is he was just commenting on the fact that Sovah Health really, from our laboratory potential to care for patients and sophistication, was really, really good. I don't know, Dr. Anderson, you want to speak to that? So folks appreciate what our labs actually do and can do here. It's really remarkable.
That's definitely worth underscoring. I think it is very fair to say that your microbiology lab at Sovah is a really good microbiology lab. The tools and tricks, and some of those tricks and tools I described tonight, if you leave, if and when you leave Sovah, especially for the trainees, if you go to other community hospitals of similar, maybe even some larger size, you may not have these same tools available to you because of how advanced the approaches are from the Sovah microbiology lab. So keep that in mind. These are tools that use them while you have them, because if and when you go to other settings, you may very well not have some of these tricks and tools at your fingertips.
Yeah, at the other hospitals, they are commonly saying we have to, quote, send this out to find out what it is. And in the great majority of cases, the Sovah labs will know. They'll let you know ASAP as soon as it's defined in the lab, and it's just great care locally. It's really nice. It really is. And part of that, of course, is DASON support that helps us do that. So it's not just our lab, but it's Duke's help with this also. Are there other questions of Dr. Anderson? I will say that Debrick is constantly available to us as a help. So if someone on the call has a thought or something later on, we'll be glad to connect you to him. He's so helpful and responsive. You start mulling this stuff over. And of course, we have difficult patients. Getting an ID consult locally with Dr. Desai are the ones that help him. And then he's in direct contact with DASON and Dr. Anderson and his team at Duke. So don't feel hesitant if you need help asking somebody to help you with this, because this is new stuff. It really is. Okay, well, let's move on to our second speaker. Thank you, Dr. Anderson.
Thanks very much. See you next year, right?
Yeah, absolutely. Oh, there she is. If you want to bring your slides up, let me share a little bit about your background while you're doing that. Dr. Elizabeth Dodd Ashley when we talked on the test connection, was nice enough to share. She's from upstate New York, so all this snow coming in may be old hat to her, and her early years where she lived at that time. As she knows, when it snows in our area in Durham and so forth, it's a snow day, and everybody's looking forward to their snow days. But Dr. Dot Ashley is a PharmD, and she is the pharmacy clinical pharmacist that is supports an operation director from a pharmacy perspective for DASON. She's at Duke University with Dr. Anderson and the rest of their team. She did her pharmacy degree, her doctor of pharmacy at Northeastern University in Boston, graduating summa cum laude from that. She subsequently did American Society of Hospital Medicine pharmacy practice residencies at Duke, and then another residency following that, a Duke and Campbell University specialty residency in adult internal medicine and infectious disease. She also holds a Master's of Health Sciences in Clinical Research. She is certified in her specialty as a PharmD and pharmacology specialist, as well as in infectious disease specialist. She has 94 published peer-reviewed articles and 7 book chapters. And we ask her to do what we do almost every year, is to come tell us about newer antibiotics, and with the surge in viral illnesses, newer antiviral drugs that may be available to our patients. So, Dr. Dot Ashley, thank you so much, and we look forward to your comments.
Thank you so much for that kind introduction. Can you all hear me and see my slides?
Yes, it looks
Wonderful.
great.
Great. Well, we'll dive right in. So our objectives, as Dr. Moore shared, we really want to help introduce you to some of the newer antibiotics and antiviral drugs, including their indications, where you can't use them, and potential side effects. But I hope what you really walk away from tonight understanding is that part of our best use for newer antibiotics, and I realize this is a challenge in drug development, is that it's important to know when they're helpful. It's also important to know where we should not use them. These drugs that are coming onto the market today, especially the antibacterials, are incredibly precise in terms of where they work. So I'm building on a lot of the information that Dr. Anderson shared about gram-negative resistance trends, and these are very targeted drugs for very certain infections. So we will quickly go over some of those new anti-infective approvals and the pharmacology of those drugs to help you get an early understanding of them. I want to talk a little bit about the future of anti-infective development, because this is an area that it's a little bit of a sad story, and it's definitely one where the landscape is shifting quickly. And then I want to introduce this, like some people say that 40 is the new 30. Maybe the new antibiotic is actually no antibiotic. And we've learned a lot about this, and I'm pretty passionate about this area. And so we're going to finish up sharing some of the most recent data in that area as well. What I have here is the timeline of antibacterial approvals by the United States FDA starting in 1983. These are 4-year snapshots. And you can see, when I graduated pharmacy school, we were kind of coming off this large trend where we were getting lots of new drugs, lots of new classes, novel agents all the time. And then a very disturbing trend happened in the mid to late 1990s, and most of the US-based drug manufacturers actually pulled out of antibiotic drug development. And so it left us with this big dearth, and we have been working ever since to try to get to where we have some novel antibiotics. What I didn't put on this chart is at the same time, the trends in antibiotic resistance have been just skyrocketing. So we are losing use of the drugs. And whenever I talk about new agents, I just want to remind everyone, anti-infectives, they're the only drugs that we put into the US market where the minute the drugs get approved, we already start to lose the ability to use them because of the development of resistance. Some of the newer drugs, and it's not even that new anymore, but for example, daptomycin, when that drug was first approved, at the time I was doing Staph aureus bacteremia research with Vance Fowler, and we went back and he actually looked in his database of Staph aureus isolates he's been saving since the 1980s. And we could find resistance to daptomycin in those isolates 20 years before the drug was on the US market. So that's really something you have to think about. These are novel agents. They're the only drugs that when I give them to one patient, I potentially jeopardize the use of that drug in a future patient. And so we really need to be thoughtful about where we employ these drugs so that we use them when we need them. We really need them sometimes, but we also save them and try to preserve them and prevent resistance development. So in the period, we just have 2023 to 2024 in that last snippet. It's just 2 years. We had 5 antibacterial agents who were approved in the US. I want you to just answer for yourself. How many of those do you think you could purchase in the United States today? So there have been huge initiatives by the US government to try to foster antibacterial drug development. There are different pull and push incentives to try to get these drugs to market. And so some would say it's a success that we had 5 antibacterial drugs approved in the last 2 years. However, what's really sad is only one of those drugs can actually be purchased in the United States today because these drugs might get approved. I'll show you some examples of how there's one drug that was approved with use in only one patient in the United States, but many more in other countries. And the reality is they can't find manufacturers to actually develop them to sell in the United States. So drugs that have been approved for over a year, we still cannot buy. But I'm still going to take you on a little tour of what those agents are and where we think they're useful. So let's dive in. So the first one I want to talk about is a drug that is not going to sound new. It's cefepime in combination with enmetazobactam. So enzenabactam, right, sounds pretty familiar. This is a fixed dose combination of a very commonly used 4th generation cephalosporin. And I think it was said, but I'm actually the Dason liaison that covers Sovah Health. I've seen your data. I know you all know what cefepime is. You use plenty of it. So traditional cefepime, and then a new beta-lactamase inhibitor that's extended spectrum. Now, when I talked about this drug, I said that it was a fixed dose combination, and you probably aren't too used to hearing that. The reason we've started referring to beta-lactamase inhibitor combinations as fixed dose, or just leaving off the fixed dose, is because we hopefully in the next 10 years will actually be moving to a system where we will separate the beta-lactamase and the beta-lactamase inhibitor. And you will be able to say, this is the beta-lactam core I want to give, and I want to use these different enzymes that inhibit various resistance mechanisms based on what I know I have locally. And when we have moved away from fixed dose combination drugs, we get much more flexibility in doing that. Unfortunately, at present, the US FDA is not terribly open or receptive to these non-fixed dose combinations. And so right now, this is what we have, but we're getting there. So stay tuned. Something on the horizon is you may, in fact, have beta-lactamase inhibitors standalone, not with its actual beta-lactam counterpart, which is quite interesting and exciting for all of us. So getting back to this drug, this is actually the drug I alluded to that has been approved with use in a single patient in the United States. So this was approved for adults with complicated urinary tract infections, including pyelonephritis. So these can be quite sick individuals, and they have to be caused by, as always, susceptible. The FDA will always put that in there. E. coli, Club pneumo, Pseudomonas, Proteus, Enterobacter, lots of different pathogens. Something that we're seeing in a lot of new anti-infectives that are being approved, especially in the beta-lactam category, is the initial FDA-approved dosing does include an extended infusion. So the drug, as it was approved, is infused over 4 hours. This is a fairly big dose of cefepime. So anything before the decimal is cefepime, after is a beta-lactamase inhibitor. So 2 grams of cefepime Q8 hours. This drug does require renal adjustment. And because we do see neurotoxicity in patients with cefepime, particularly if they're not correctly dose adjusted, neurotoxicity has been reported in patients receiving this drug. So the big trial that got this drug approved looked at both men and women again with complicated urinary tract infections. And what they saw was the drug actually had better primary outcome of clinical response compared to piperacillin and tazobactam. And the reason for that is this enmetazobactam is an extended spectrum beta-lactamase inhibitor. So if you remember the results of the Merino trial, so the Merino trial compared patients who got quote unquote traditional therapy, most often piperacillin tazobactam, to that of carbapenems for patients with ESBL bacteremias, and showed that there was actually a benefit in mortality to give the carbapenem. That's why in Deb's talk, he said, when we have ESBL in the blood, we're going to give a carbapenem as our first line agent. This actually may help us move away from that, so that with the enmetazobactam, that actually does work better against ESBLs, and we think it will be improved outcomes there. But right now, the data for this are in these complicated urinary tract infection patients. This is an IV agent. This is one of the ones we cannot yet buy in the United States. So stay tuned. It actually now has a marketing partner in India, and so we are hoping that we will soon have it in the United States. They're predicting second to third quarter. And I think this is definitely a new trend. This is not something I'm used to in my career as a pharmacist, where a drug gets approved and it takes over a year for us to be able to purchase it, which is a little bit frustrating when we're trying so hard to have new treatment options for our patients. I think when we were all very excited about was the approval in 2024 of ceftobiprole. So ceftobiprole is a 5th generation cephalosporin antibiotic. I want you to think ceftaroline in terms of spectrum because it covers MRSA, and that's what makes it a 5th generation cephalosporin. This drug actually went in big and got 3 initial FDA indications when it was approved. It is approved for Staph aureus bacteremia, including MRSA, and I think that's the most exciting for all of us. It also, as any anti-MRSA drug comes into the US market, has trials that show its efficacy in skin and skin structure infections. And this drug also has an approved indication for community-acquired pneumonia. Now, I need to pause here and put my steward hat on. Just because a drug that covers MRSA has been approved in the United States to treat community-acquired pneumonia, I do not want you to walk out of here today thinking that patients with community-acquired pneumonia need anti-MRSA coverage. That is actually incredibly rare. Now, you do read case reports about patients with community-acquired pneumonia being infected with MRSA. It very often occurs, or it's most common in patients who have post-influenza pneumonias. And I will say that phenotypically, patients with MRSA community-acquired pneumonia look different. These are not your elderly patients who come in after a few days to a week feeling unwell and are continuing to dwindle. These are typically the young, healthy, often very athletic patients who are eating Wheaties at breakfast and are intubated at lunch. So that very rapid progressive course, you definitely need to think MRSA, especially if it follows an acute viral illness that may have been influenza. All right. Back to ceftobiprole because we're very excited about this drug. Now, if you look at it in vitro, it says that this drug actually covers Pseudomonas, and this is an area of great debate. We are not sure yet about the clinical utility of this agent against Pseudomonas, and right now, I don't think there's anyone who would feel comfortable empirically treating patients with presumed Pseudomonas with ceftobiprole. If you could buy it. You also cannot buy ceftobiprole. They have not found anyone to manufacture this drug, and they don't have very many bright horizons when we checked in about 6 weeks ago. This drug in clinical trials of hospital-acquired pneumonia actually did worse than comparative agents, such as piperacillin tazobactam. So nobody feels real confident saying that we can use this to treat pseudomonal infections. It's administered as a prodrug, and it has a very interesting load, one of the longest loads I've ever seen. So if you're going to use it for Staph aureus bacteremia, you actually have to give it 3 times a day for 8 days. The other indications all require no more than 7 days of treatment, so that is not required. And it is renally eliminated, so we do need to worry about it. If you are interested in learning a lot more about ceftobiprole, I'll put in a shameless plug that as members of our DASON network, all of the providers at Sovah Health are eligible to receive our DASON newsletter, and our August edition actually focused entirely on use of this new agent. If you'd like to be included in our list to get emails about this, you can reach out to me after the program. You can reach out to Kevin or Amy or Heather in the pharmacy, and I know that they'd all be willing to help you get on our email list to get these newsletters. So the study for ceftobiprole, and I'll go ahead and populate these. There's a New England Journal article. This is actually It was led by Tom Holland, who's in our group. He gave our CE-based webinar, so another shameless plug for DASON content, but we do webinars every other month to educate on various aspects that are common across our community hospital network. Tom is great. You know, whenever we can have a world expert come and give the webinar, that's what we do. And Tom actually gave a recent one on treating Staph aureus bacteremia. We have the recording if you're interested. But basically, ceftobiprole was non-inferior to daptomycin for treating Staph aureus bacteremia, which is, again, pretty exciting to us. We had hoped when we first had this drug in clinical trials, it would be a little bit better at treating more of the gram negatives. Not quite there yet. But you can see they're pretty comparable to other agents in terms of efficacy. So again, an exciting new option. We are excited to get it in our hands, and stay tuned for when we might actually be able to purchase this. Now, pivmecillinam, I'm going to quickly go into a few drugs, not show as much of their clinical trial data. We have a whole host of drugs coming out to treat urinary tract infections. This is an oral agent. It is approved very specifically for female adults with uncomplicated UTIs. This is technically a new drug in the United States, but it's not new to Europe, and it actually has been approved in Canada for some time. And so you can actually see pivmecillinam in the IDSA guidelines for treating urinary tract infections because it is so widely used in other areas of the world. This is a beta-lactam antibiotic prodrug. It's a prodrug, so you have better absorption of the beta-lactam. It has typical uropathogens. It has treatment approvals for as little as 3 days to treat these uncomplicated urinary tract infections, which is great. Things to know about it. It does have cross-reactivity with penicillin. So we need to think about that in terms of patients with allergy, although once again, if we do appropriate allergy screening, the structures are not that similar, and so you usually can get away with it except for in patients with true severe anaphylactic reactions. And it can cause acute porphyria in small numbers based on the experience in other countries. But remember, unlike many new drugs, we have a lot of experience with this because it's been available for years, actually decades in Europe. So we know a lot about its safety profile. Again, approved, not yet commercially available. And I don't really have a great reason for that because, again, it's sold in other countries and clearly they can manufacture it there. So stay tuned. This may be available to help you treat your patients, maybe as they're transitioning to outpatient therapy. One of the most recent approvals came in October, and this was of sulopenem, and I'll tell you, our office has no agreement over how to pronounce this next word. I say adzadrazine, but other people say it many different ways. I apologize if that's not what we land on, in combination with probenecid. So this is a penem, sulopenem, and in combination with probenecid. And honestly, the way I have filed this away is it might be the closest thing we ever get to an oral carbapenem. It does not have great absorption, as I'm sure you probably guessed by the fact that we have to co-package it with probenecid just to administer it. This is also approved only for uncomplicated urinary tract infections. And it is very specific. It's only for treatment of uncomplicated UTI in women with no alternative oral treatments. So organisms in theory should be resistant to other available antibacterials before we reach for this drug. Due to a few issues. It's a little tricky to administer. You give it twice a day, 5-day treatment duration in these uncomplicated UTIs is what was studied. It needs to be administered with food. It's problematic in patients with blood dyscrasias. It's known to cause kidney stones and exacerbate gout. So a little bit tricky to give. Some of that's because of the probenecid component. So something to watch, also completely unavailable, but this is the newest FDA approval that we had just a few months ago. Now, the one we can buy, sulbactam durlobactam. This is a very novel drug, and I think when you try to hear about the drug class to which this drug belongs, there's a little bit of debate. So I think what people are landing on, because it's familiar terminology, is they call this a beta-lactam and a beta-lactamase inhibitor. It actually is using the sulbactam. So we're used to sulbactam, sulbactam, we give it a lot. Sulbactam is being used here for its anti-infective properties against Acinetobacter. We've known for a while that in patients with Acinetobacter, we can give them sulbactam. And if we can get that dose high enough, we get some activity. It's actually from the sulbactam. So it is technically a beta-lactam and beta-lactamase inhibitor with a second beta-lactamase inhibitor, which is the durlobactam. So together, these work, and these are only approved for patients greater than 18 with susceptible isolates of Acinetobacter. So a very specific patient population with very specific resistance mechanisms. Unfortunately, you have not had reason to use this yet, which is fantastic. It is a little bit confusing where these go, and I'll show you a slide in a minute of some great resources, but durlobactam does not help against metallo-beta-lactamases, and so it's really not helpful in that setting, but is in other places. Now, sulbactam, durlobactam is not on the commonly available antimicrobial susceptibility testing cards. It was very nice. Doctors Anderson and Moore had a nice conversation about your lab. I cannot say enough good things about Pam and her team and everything that she does for Sovah Health, but this would require special testing, even with the newly implemented automated susceptibility testing cards. Excuse me. This is another agent that like earlier, beta-lactam, beta-lactamase inhibitors I discussed, the initial approvals are all based on extended infusions of these drugs, which we can talk about the pros and cons if you want. There's actually some interesting studies that looked at that recently. Happy to discuss that if that is of interest. So the big trial that got we call it Subdurlo approved, was a trial in Acinetobacter that compared Subdurlo to colistin for treatment of patients, again, with Acinetobacter infections. They actually had improved 28-day mortality compared to colistin. And really the reason was, probably not surprising, this drug is much better tolerated. And that's what you see here on the right-hand side. The toxicities related to colistin are really difficult in the ability to continue therapy. And so this is where that drug can really shine in those Acinetobacter pneumonia patients or bacteremia patients. So pretty severe infections, very helpful. This drug is the one that we have. We've used it a little bit at Duke. We have a little bit of experience with it, but still not a mainstream drug. This is one of those agents that when Dev was talking about the BCID2 results and it had the highlights that said you would probably reach out and contact infectious diseases, certainly to get access to an agent like this, that's what you do. Probably the same will be true for the other new agents I've talked about. Again, we can't purchase them yet, outside of the oral agents that we can use to treat urinary tract infections. Now, we have all these drugs coming out, and I always like to show this. This is a DASON resource, and we can share it with you if you like. We stay very much up to date on this. But these are all of the quote unquote newer, and some are not very new. If you look over there on the left, we have drugs that were first approved by the FDA back in the 50s on this list. But it does show you where these agents have a role and where you might want to deploy them based on the organism that you identify and the different type of resistance mechanisms that you are seeing. And now because you do have BCID2, we have the ability to look for some of these, which is nice, but I think sometimes with knowledge comes a little bit of confusion over what does that mean and how do I sort that out? We have resources to help you. And while I didn't bring many slides about it because it is not US FDA approved, fosfomycin, a drug you may be familiar with as an oral agent to treat urinary tract infections, actually has an IV formulation that's already available in Europe. They are working very hard to bring it to the United States. We've actually brought it in for a few patients on compassionate use as part of mostly transplant patients in the Duke programs. But fosfomycin is also a possibility and available for IV treatment in the future. So stay tuned to that because I think that may become available for some of these other newer agents that we've already talked about. So those are the antibacterials. That's really the class we have from 2023, 2024. It's not big. I think that you would be fair if you said, and there's really nothing novel there, Libby. Absolutely right. There's not too much novel in that group. You know, it's kind of rearranging the way we've thought about things, maybe a slightly more extended spectrum beta-lactamase, you know, maybe the combination of two beta-lactamase inhibitors, but really nothing novel. And there's not much novel on the horizon. I will show you, though, some things in just a few minutes about drug development that might change that. I was asked to talk about antivirals, and only because it used to be my passion, I would be remiss to not talk about at least one antifungal. So let's quickly take a tour of those before we pivot to other topics. When I think about antivirals, there's really not been a lot new. You know, right before the COVID pandemic, we got a few new drugs that would help us treat influenza. I think that we still struggle with where those might fit in most appropriately in hospitalized patients. But I think now, as we have continued through treating COVID-19, I think people struggle with what to do today. So I just wanted to make sure everyone is aware of this. I will give full disclosure. Some of this might be because I have octogenarian parents who on this very day are sitting in their house in Florida with COVID, and we could not get them treated because one of them is on rivaroxaban, and the other takes an SSRI. And because of the drug-drug interactions, there was a lot of confusion. So I just wanted to quickly go through some of the treatment options that are out there, just to remind everyone. So treatment for COVID-19 and antivirals to treat COVID-19 has largely pivoted to outpatient treatment for very many reasons. One is you have to treat this early to have any effect. And the primary agent we use is the primary agent we use is nirmatrelvir, which I always struggle to say, and it is co-packaged with ritonavir. And because of that, it has a lot of drug-drug interactions that really slow down its use. I mean, they couldn't be used in my father who takes rivaroxaban as an example. It's just too hard, and we weren't comfortable stopping his anticoagulation, for example. But you are not out of luck if you have a patient who you cannot manage drug-drug interactions in. There is another agent that is the co-packaging of nirmatrelvir with ritonavir is actually FDA approved now, which is how I snuck it in here in the 2023-2024 drug approvals. But there is an emergency use authorization for another agent called molnupiravir. And molnupiravir has some problems. It did not work as well in clinical trials, absolutely, but it does not have the drug interactions because it does not have the ritonavir component. And where it does seem to have help and is recommended on CDC, and this is actually the ASPR guidance document, where this may actually have the biggest help for you is if you have a patient who tests positive for COVID-19 and they have not been immunized with the current vaccine, there was benefit in that subpopulation. So this may be where it really helps. Now, the other antiviral agent we have to treat COVID-19 is remdesivir. We've had it for a long time, or is one of the first FDA-approved drug for COVID-19. I'll tell you, we're largely moving away from this. The reason is by the time we're seeing patients in the hospital, they're out of the window. It really doesn't help them then. The patients who are being hospitalized are actually being hospitalized for inflammatory symptoms. There are other agents that are more appropriate to treat that are outside the realm of antivirals. It's really when we get into the biologics and the steroids and things like that. And so we have largely moved away, except in very targeted patients in the Duke Health system, from even using inpatient remdesivir. So really something to think about is that the trends are that we are leaving remdesivir behind. Maybe in a few hospitalized patients, it makes sense. Maybe in patients who are right on the cusp of hospital admission very early in their treatment course, we'll bring them in, and especially if those drug-drug interactions, you might treat them with remdesivir then. But you have to get it into them so early. It's not valuable later on, and all the data have borne out that way. It's much better to work at treating the inflammation than to worry about the antiviral at that point. It is always important, drug-drug interactions. As a pharmacist, I have to show you this. If you don't know what to do as a best source, we are very big fans of the Liverpool COVID-19 drug interaction checker, which you can just put the whole regimen in and it will tell you what to do. We absolutely love this resource. You can just Google Liverpool COVID-19 drug interactions. They have lots of other great drug-drug interaction resources as well for other disease states. And then there was a very recent article in Clinical Infectious Diseases that actually looked at the combination of nirmatrelvir with ritonavir compared to placebo in patients. And it showed a lot of different things. So these were all ambulatory patients. Then it looked at not only treatment outcomes, which over on the far right, you can see that patients had some immediate relief of symptoms that was faster in the group who had the active treatment, as well as the 3-day improvement in time to symptoms. But in the kind of middle slide has the overall healthcare utilization. And what we really were impressed with here is when they had active treatment, they had a much less likelihood of having a follow-up medical care visit related to COVID-19, much less likelihood of hospitalization. And for the actively treated patients, And there were over 600 patients in each of these groups. Again, ambulatory patients treated with oral treatment early in their course of disease. None of them went on to go to the ICU or have mechanical ventilation. That is a big deal. And so really showing that it is worth treating these patients early in the community when you can. All right. My one antifungal slide is abrexafungerp. I think it's the most fun new drug name to say. It technically, I believe, was approved last in 2022. This is similar to an echinocandin. Echinocandin has a little bit different target, though, for it. It has great retained activity, might actually work for Candida auris, which Deb talked to you about a little while ago, but also has data for vulvovaginal candidiasis, pretty easy treatment regimens. You can actually treat VVC with a single day 2-dose regimen for this. It does have drug-drug interactions with cytochrome P450, 3A4, P-glycoprotein. So a lot of drug interactions, doesn't really get us out of that, like the which we are often striving for with avoiding azole treatment, but is out there and available. This one you can actually buy. So an interesting new agent that is also coming on the US market. Lots of novel agents still in clinical trials. I think antifungals are going to be the area in the next 3 to 5 years that see a lot of new drugs. So the future of anti-infective development. We are really at a crossroads. We do not have a lot of great things in the pipeline. The Infectious Diseases Society of America in around 2009 called for 10 new antibiotics by 2020. They say we technically met it, but it's all through different combinations of beta-lactam, beta-lactamase inhibitors, and a new aminoglycoside. And I think that if I talked to you in 2009 and said, we are going to have 10 new antibiotic drugs by 2020, and I told you that you were going to get a new aminoglycoside, I think you all would have laughed me right out of the room because nobody was looking for a new aminoglycoside. And in fact, that drug has already failed and has been pulled from the US market, sadly. So where are we headed? What are we doing? There is a ton of interest in phage therapy. This will be different than traditional drug approvals because these are viruses that we send in, we give to patients, and then they infect the bacteria and cause bacterial death. They are very specific to the individual pathogen and resistance mechanism. When you read case reports in New England Journal of Medicine about this, what has happened is a patient is infected with a particularly resistant pathogen. The pathogen is sent to one of the research labs that make these, and it is a patient-specific cocktail. There is a lot of research. There is a group, it's NIH funded. They're called the Antimicrobial Resistance Leadership Group, ARLG. And ARLG is doing a lot of work to help develop and bring to market phage therapy. The issue is the desire is to have a single phage cocktail that would work for the most common resistant gram-negative pathogens, and nobody can agree what goes in that cocktail. So stay tuned, but phage therapy is certainly seeing success in several patients. But right now, today, to do it, it's investigational, and it is completely a patient-specific drug that is made on a case-by-case basis for individual cases with gram-negative resistance. Here is a nice summary slide from recent clinical trials of all the different organisms that are currently investigating phage therapy and how many studies, what phase they're in. And you could spend a whole bunch of time. I actually spent some time last year at an ARLG meeting learning about all the different phage targets. It's absolutely fascinating. I think we'll see a lot of this in the future. And this is particularly how we can, in my opinion, best address pan-gram-negative resistance today without the availability of novel anti-infective drugs on the horizon. AI is being talked about everywhere. I'd be remiss to tell you that AI has also wandered its way into drug discovery. So a group of researchers at MIT actually were able to develop this new compound. It's called Halicin. It's named after a famous movie that I don't know, so I apologize if you do know the movie. But it is a drug that was previously known. It is not traditionally thought of as an antibacterial, but they were able to show that it actually would work. It started first as an anti-diabetic drug, and now it took it took 10 years for it to fail for treatment of diabetes. The lab at MIT, it was part of a contest. They identified this as a potential antibacterial agent in 3 days at the computer. Absolutely fascinating. And it's actually bearing out in some preclinical work. So stay tuned. I don't know that Halison's ever going to make the market, but we are using AI to get us faster to drug targets that may actually work for our most resistant bacterial pathogens. Now, before we close, I really want to explore just for a few minutes this concept of maybe no antibiotic use is the way that we need to go. And something that our group does, and I'll do one more shameless plug before this is over, is we have realized, and our founder, who founded both Dicon and Dason, is Dr. Dan Sexton. Some of you may have heard him speak before, may even have worked with him as colleagues. And he always taught us that a lot about antibiotic use, it's not that anybody tries to use antibiotics inappropriately, it's that people have a lot of what we call confidently held misbeliefs about antibiotics. An easier way to say that is people believe myths about antibiotic use because they were taught or because we always thought it. And then as these things are disproven, it's hard to get that message out there. And so our group at Dason has actually taken a keen interest in these myths. I'll show you some papers at the end that us and colleagues over in California have written. But traditionally, when antibiotics were studied and approved, they were always given in durations that were 7, 14, or 21 days. And what we have since learned is those treatment durations are not necessary. And there are reasons that we did longer. I mean, when I was in high school and I worked as a pharmacy technician, I put a sticker on every oral antibiotic that said complete your course because there was concern about infection relapse. But we actually know based on several studies, but many of them in pneumonia, that shorter durations do not lead to relapse, and longer durations actually lead to relapse with resistant pathogens. So we need to dispel that you have to take a full course. And there's some compelling data that actually patients who stopped their antibiotics when they felt better, did better, and had fewer subsequent resistant infections than those who took the whole course as we were instructing them to do. Now, there used to be a belief that if you treated for longer, you could eradicate all the pathogens and prevent antibiotic resistance. Absolutely not true. And then some belief that the longer durations are just, quite frankly, more effective. Also not true. And you'll see one name cited many times here, and that's Spellberg. Brad Spellberg is actually a physician administrator now at UCLA, and he has spent a lot of time talking about excessive antibiotic durations. And so he has come up with these websites. So he has a few publications, and his mantra is shorter is better. His website is shorter is better. And I'll show you a link to that website. Please be sure you have the exact website, and don't just Google that term. But in terms of duration, it is just better to treat the minimum amount of time. We have less risk of having C. difficile infection. Again, as I mentioned, lower risk of developing resistance, and we reduce the burden on healthcare because it's less time, it's less cost, patients go home faster. Everything just improves when we use shorter durations. There's also a group in Michigan who's looked a lot at transitioning patients out of the hospital with antibiotics and what works well and what doesn't. And we know that that is an area where we actually can reset the clock a lot. And so this group is led by Valerie Vaughn. And what she found in one study that looked at discharge interventions around patients with pneumonia who were getting prolonged courses of antibiotics is that every excess day of treatment beyond the typical 5 days that's needed to treat community-acquired pneumonia, every day was associated with a 5% increase in odds of an antibiotic-associated adverse event after the patient left the hospital. So think about that. That's pretty significant. Antibiotic adverse events are one of the #1 reasons that patients present to the ED if it's going to be a drug-related toxicity. So it's something for us to really pay attention to. So using antibiotics, I think we all think, oh, it's a safety catch, right? If I keep them on and they're doing so well, why stop a good thing? Well, because these antibiotics also have unintended consequences, and we need to be mindful of those. We have spent a lot of time looking at this, and one of our other liaison pharmacists, April Dyer, looked a lot at this. And what we found is in 3 different Dason hospitals, this was several years ago now, when we looked, there was sort of modal use of antibiotic durations. So some hospitals had 7 days, some hospitals had 10 days, and this really tied to the automatic duration. But even more shocking In our experience, up to 60% of the total antibiotic course attributed to a hospitalization happened after discharge. So you have a patient who might be in the hospital, treatment for cellulitis. You want to treat 5 to 7 days. They're in for 3 or 4 days. When they go home, boom, they get an automatic duration for 10 days on their prescription. It's really a problem. And it's kind of like that we spend so much time on stewardship in the hospital, we don't think about it as much when they go home. So I really hope that I really want you to think through this and think about the total duration. This is Brad Spellberg's website on Shorter is Better. There are numerous indications for which we have shown that traditional longer courses of 7 or more days are simply not necessary. Now, sometimes they are. You'll see longer courses here for deep-seated infections and other things, but we're down, gram-negative bacteremia used to be 14 to 21 days. We feel pretty confident at 7 days. And there was actually a recent publication, topic of our DASON December newsletter, is the balance trial that again shows shorter courses are just fine for gram-negative bacteremias. So we're really pushing this to try to shorten it. Now remember, your average hospitalization is just 3.5 days in the United States. And so some of these things like community-acquired pneumonia, you may not even need to send a patient home on any antibacterial treatment at all. So our myth is that antibiotics need to be 7, 10, 14 days in duration, but the reality is that it needs to be best based on the patient, how their clinical course is, and responding patients can usually get very short courses of antibiotics. We have guidance for you on this specifically at Sovah Health. On the other side of those antibiograms that Dev showed you earlier, there are these treatment guidelines that talk about what we suggest for inpatient therapy, a great option for oral or outpatient transition, and then the total duration. Remember, add up the days they got, not just of the current drug. If they came in and they started on piperacillin tazobactam empirically because they triggered a sepsis protocol, and then you end up deciding that they just had, not just, but that they had a community-acquired intra-abdominal infection instead, you can treat those with 5 days, and the pip-tazo still counts if it covers the pathogens that you wanted to treat. I will also put a plug in. We have looked several times at antibiotic appropriateness in hospitalized patients nationwide. And when we did it in the just before 2010, we had about 50%, a little bit more, 55% of antibiotic use was unnecessary, excessive. And when we repeated it almost a decade later, same results. So what I would challenge you is to everyone on this call, when you go in the hospital every day, if we know that 50% of our antibiotic use is excessive, I challenge you, find one patient on one antibiotic. It could be somebody who's on 2 antibiotics. You just have to pick one. Every day, try to stop one antibiotic. It will make a huge difference in preserving the antibiotics that we have to treat the patients, because I've shown you what you have coming. Unless you want a lot more aminoglycosides and beta-lactamase inhibitors, we don't have much in the pipeline. Now, if you're intrigued by these myths that I talked about, our group, as well as Brad Spellberg's group, have published a series of papers on these antibiotic myths for people in hospital medicine, for infectious diseases clinicians, and then there's Brad Spellberg that talks about the inertial dogma. So I encourage you to reach out if you'd like. We're happy to share these with you. We can talk about myths all day long. But I do want to wrap up and be respectful of everyone's time. So we certainly do have newly approved anti-infective agents. I would love to talk to you about them more and when we're actually using them, but they aren't in our hands yet, and that's really frustrating. So we know, though, that it's going to be important to use these agents wisely. These can be very targeted to specific resistance mechanisms, and luckily at Sovah Health, you have the ability to test for them and can give them to the right patients. And we are hopefully developing and putting tools in your hands to make those correct matches where they're needed. But we have to use them wisely or we will lose them too quickly. We know this all too often. The greatest example is carbapenems. While they work best for ESBLs, they also are the biggest inducers of ESBLs. So when we use them indiscriminately, we actually cause more of the problem we're trying to treat. So we need to be thoughtful about this. But these are interesting times. I wish I had better stories to tell about the anti-infective drug pipeline, but it's just not where we are today. So I appreciate you all taking time to listen and your evening. I hope everyone stays safe in the snowstorm, and I'd like to open for any questions that people may have for me.
Any questions for Dr. Dodds, Ashley? This is your chance. I do want to reinforce the fact that if you do have just a lot of new information, and if you think about this and reflect on it, if you'd like the references or so forth, just let us know. The slides are available as far as specifics, and the Dason good folks can be contacted, Yolanda Poole and the others in the lab, and as well as the pharmacy folks, Amy Berkheimer and Ashley. They all have contacts and can connect you with the folks at Duke for any of this information they provided. Okay, well, thank you so much, Dr. Dodd Ashley. We appreciate it so much. Mary, was there anything in the chat before we close?
No, no, I've just put the QR code if people want to access the
Okay.
evaluation in that way.
Okay, dope. Well, I hope everyone on the call this evening will rejoin us in 2 weeks on the 30th. When Dr. Mooring is from Duke is going to actually talk specifically about outpatient antibiotic stewardship, patients in the ER, patients going home from the hospital, and then patients initially not in the hospital, but actually seen in the clinic where probably the majority of folks receive their care anyway. So I hope you'll be on the call for that. And for those of you who are collegiate football fans, the score is 0-0 after the first quarter of the Orange Bowl. So if you're going to go home and tune in, you probably haven't missed anything except a lot of punts and 3-and-out runs. So hopefully everybody will stay safe. But there is going to be snow Friday afternoon, Saturday morning. So take care of yourself, Mary. Again, thank you for your help, and Van. I don't know if Van's on the call, but thank you all so much. Have a great evening. We tell the residents each time I meet with them, please be careful out there. And we hope to see you back on our next program. Bye-bye. Thanks a lot.